Hello everyone. I'm Dr. Akhil Tawari and I'll be talking on how to improve outcomes after vertebral biopsy so that there is more of scientific basis and less of assumption in taking care of tuberculosis. The first question is why we need to do biopsy. Why not just go for empiric treatment based on MRI findings? MRI is so sensitive. So this is a 7-year-old patient who presented with back pain and fever. MRI was done showing a huge abscess, findings suggestive of Cox infection. We did a biopsy. It did turn out to be Cox, but came out as resistant tuberculosis. So if based on MRI category 1 would have been started, it would have led to disastrous results. Another patient, 74 years old, based on MRI findings, started on empiric AKT, took it for a month, did not improve. We got a biopsy, turned out to be fungus. So the current recommendation is to get a tissue diagnosis and culture for all cases of suspected tuberculosis, putting in all efforts that we can. This will help us to avoid improper, unnecessary, and prolonged empiric treatment. As far as tuberculosis goes, we need to do a combination of gene expert, bacterial culture and sensitivity, as well as histopathological examination, see them in unison, and then come to the diagnosis to get the best diagnostic yield. The question really is how to get an adequate and representative material that is so crucial to diagnosing and treating spinal tuberculosis. Well, for tuberculosis, the challenges are multiple. First of all, it is a paucibacillary infection, low-grade and fastidious organism. Secondly, sometimes we see patients who have already been started on tuberculosis drugs empirically, and also there are some sampling errors. To get the tissue diagnosis, one can do biopsy through the percutaneous or the conventional open approach. Percutaneous is fluoroscopy and CT guided most of the times. Now, percutaneous method has gained rapid adoption in the last couple of decades, and for the simple reason of being less morbid and a daycare procedure. It is, however, a technique-driven procedure, and if we see the positivity yield, it has been found that it ranges from 36% to 91% in infective spondylodiscitis. However, if we study the literature more keenly, the higher percentages are seen in recent literature, which means that something we have started to do correct in getting a good yield. Now, percutaneous CT scan is considered to be the gold standard. However, a lot of spine surgeons are adopting percutaneous transpedicular biopsies simply because of the familiarity with percutaneous fixation, and it is giving equivalent results as compared to a CT guided biopsy. If we do literature review for any spinal lesion, infective or non-infective, there are some factors which are favorable, including thoracic levels and whole vertebral body involvement. And there are some factors which are unfavorable, which also includes infective spondylodiscitis. So what are the real causes to get a false negative report? Usually it is an inadequate sample size, a sampling error, or biopsy of sites which are devoid of living organisms. For example, in tuberculosis, if we go for biopsy of the edematous bone, then there is a high possibility that we may end up getting a false negative report. So how to increase the yield? Where there are some factors that we can do from our end so that we don't have to get a false negative report as much as possible. First and foremost, the biopsy material that we choose. So it has been found that for culture, the granulation tissue yields more living bacteria rather than the pus. Bone tissue is least favorable, so we should avoid ending up with just getting a bone biopsy. Now, whenever we get the sample, it is usually sent for the gene expert and the culture. Gene expert uses microfluidic technology, is quite rapid. We get reports in 3 hours. And what it hunts is actually the genetic material of the bacteria. It has been found that liquid samples, that is the pus or abscess, is more sensitive to be picked up by the gene expert. And if we just send bone, then the report will come as false negative. Consider the culture. Culture is the gold standard, but may take up to 6 weeks. And if there is primarily bony tissue, then culture is more reliable. Second is the needle factors. So it has been found that needles with larger inner diameter will give us more material and hence higher chances of a true positive report. Also, for non-infective lesions, needles with serrated edges give better yields as compared to ones with beveled edges. Hence, it is important that we use larger diameter needles if we are doing it ourselves, or we prod our radiologist colleagues to use larger diameter needles while doing a CT scan guided biopsy. Just a comparison. So we look at the different needles, gauge size and internal diameters, and we can see that if a 15 gauge needle is used, the internal diameter is 1.3 and it is almost twice if a 11 gauge needle is used. Of course, using a 11 gauge needle can lead to pedicular violations and damage to the spinal cords and roots, which we have to be cognizant about. In case of lesions from the vertebra, how do we know whether it is adequate or not? So Arribas et al. Have laid down certain macroscopic and microscopic factors to know the adequacy. They look at the tissue quality, whether it is cohesive core or fragmented tissue. Usually fragmented tissue yields a negative report, and microscopy is to get a cytology done and then to know whether the material is sufficient. A point to note is necrosis and blood are considered to be insufficient material and should not be sent because they will give you a false negative report. Some modifications have been done. So we have a paper by Babu et al. Who advocated scrape cytology, in which a tissue was scraped and then they also did a cytological analysis and got a good positive report. Similarly, Basu et al. Have introduced a modification in which they used a kyphoplastic cannula and then used a 3 mm kerosene, 3 mm pituitary forceps to actually get the bony tissue or the disc tissue. The question really is, what next if a tissue biopsy comes negative? Right now, there are no strong recommendations. However, if there is a strong suspicion, probably a repeat percute biopsy should be considered, or we go for the conventional open biopsy if non-tuberculous etiologies are also possible. Now, open biopsy is the most reliable method. We get a huge amount of tissue, but has the obvious drawback of needing anesthesia. Hence, it is usually reserved if there is surgical indications. The take-home message is, diagnosis of tuberculosis, we should make every effort to have a tissue diagnosis. Paying attention to the tissue type, needle size, and sample characteristics can help us to significantly improve our yield. Thank you.